Hello again, and welcome to week 3 of dental local anesthesia. I'm Dr. Varela, and I'm so glad that you're with me today. Just to give you a heads up, this lecture is probably going to be a little bit shorter than the last two lectures. The last two lectures were pretty long, and it's not because the content of today's lecture is any less important. It's actually because there's just so much to consider that I didn't want to throw everything at you at once. One of the other things that I want you to know is that we're probably going to have, in addition to the quiz for this particular week, week 3, we're also going to have you go through and read just a couple of evidence-based articles that talk about local anesthesia and maybe have you answer some questions with regards to those. So look out for those in Canvas. Most likely what I'm going to do is I'm going to have them be posted to the download section for week 3. So in addition to this PowerPoint discussion that you'll download, you also download the other two papers that I want you to read, and then we'll have a separate quiz for that. So last time we talked about the pharmacology of local anesthetics and vasoconstrictors. And we also talked about how the pH of an environment can really influence what form those local anesthetic molecules take. Now you'll remember that they take one of two different forms. They either become free base form or they become the cationic form. Now we also went on to talk about the vasoactivity of both of these substances, the local anesthetics and vasoconstrictors, and what that vasoactivity actually means to the human body. And today what we're going to do is we're actually going to go over some specific details of the local anesthetics that you will be working with in dentistry. Now hopefully you remember from the last time that there are two different classes or types of local anesthetics. There are the amides and the esters. Now on the right of the screen you can see here that we have the esters. But what I want to do is actually start on the left side of the screen and talk about the amides. Now, some of these might sound familiar to you, especially the ones that are in bold. And these are the amides that are still being used in dentistry today, particularly in the United States. Now, the exception to that is etidocaine. Now, etidocaine was originally marketed under the trade name of Duranest. And it was originally marketed for its ability to produce prolonged anesthesia, which basically means that its effects lasted a really long time. Right around 2002, it was removed from the North American market as no longer available in the United States. So that's why it's not bolded, and that's why we're probably not going to spend a whole lot of time talking about it. Now, the last line there on the left here, it talks about EMLA, which stands for eutectic mixture of local anesthetics. And EMLA is actually a cream that contains both lidocaine and prilocaine in it. And you should probably know that for the boards. Now, there are some other mixtures of local anesthetics. The other one that comes to mind is a mixture of lidocaine and prilocaine, again, both in about 2.5% each. And the product that we use that uses this mixture is called Orachix. And we'll talk about Orachix later on. Now, out of all of the amides listed, lidocaine is not only the most commonly used local anesthetic in dentistry, but it's also considered to be the safest to use, especially in pregnant women. Now, here at the school, it is the drug of choice when treating a pregnant woman, unless it's otherwise indicated by the patient's physician. Now, moving on to the right side of the screen, we see the esters. Now, we do use ester anesthetics in dentistry, but usually it's in topical formulations, the most common being benzocaine here. And benzocaine actually comes in a lot of different trade names. It's called Hurricane in some parts of the country, but benzocaine is really the one that we use. Now, last lecture, I briefly mentioned that allergies to amide local anesthetics were really, really rare due to the innocuous nature of these local anesthetics. Now, if a true hypersensitivity to an amide is actually encountered, then the use of an ester should provide anesthesia without those allergic effects. Now, for the purposes of today's lecture, I'm really going to limit our discussion of local anesthetics to the ones that we actually use, not only here in the clinic, but really what you're going to encounter later on in your career as a dentist. Now, it's going to be really important for you to know everything I will present to you about these local anesthetics, that you know how and when they can safely be utilized, especially when you get down to the clinic. Now, I said that we were really only going to be discussing the local anesthetics, and as you can see here, most of these are amides, and that's partially true, but I will touch upon one local anesthetic that's not on this list, and that's no longer used as a local anesthetic in dentistry, but the reason we're going to cover it is because it has a very important historical significance to our discussion about local anesthetics. But before we get into that, let's revisit a topic that I really briefly touched upon in our very first lecture. Now, you'll remember when I talked about the spectrum of sedation, and I brought up this topic of individual response. So you just never know how an individual patient is going to respond. Now I'm going to take that and I'm going to frame that discussion in terms of the duration of action of local anesthetics. Now remember, we talked about these desirable characteristics that we want our local anesthetics to have, and duration of action is one of those desirable characteristics that we want our local anesthetics to have. Many factors other than individual response can influence both the depth and duration of action. And those factors include, in addition to individual response to the drug, accuracy of deposition, the chemistry and biology of the tissues, anatomical variations, the type of injection you give, the accuracy, and so forth. But I'm really going to start the discussion by focusing on the influence of individual response on the duration of action. So in order to look at how the duration of action is defined by an individual patient's response, let's say that we have 100 patients. Now, let's say further that we give each one of these patients an equal amount of the exact same local anesthetic. Now, their individual responses, as we will find out at the end of this experiment, can actually be charted along a normal distribution or bell curve, and you see that right here. Now, as you can see on this bell curve, this middle section here represents the majority of patients that will respond in a predictable manner, and that's roughly 70%. I'm sorry, it's really 68.26%, but we'll call it about 70%. And we'll call this group normal responders. Okay, these are the people who can react very predictably to a drug. Now, the patients to the left of the middle section are the 15% of patients that probably won't be anesthetized for very long. Okay, and we're going to call this group hyporesponders, and these are the people who you give them local anesthetic and they just don't stay they don't stay numb for very long. And finally, here on the right side of this middle part of the curve, we see the 15% of patients whose anesthesia will last longer than expected. And this group we want to call the hyper-responders. Now, out of these three groups, which do you think is the most difficult group in dentistry to manage? And I'll give you a second to think about it. Now, if you said the hyper-responders, you would not be correct. This group is actually one of the best groups to work with because you give them a little bit of anesthetic, and that little bit of anesthetic goes a long way. If you said the normal responders, you would also be incorrect because these people will respond very predictably. You'll know that you give them the local anesthetic that you're going to give them, and you can very safely predict that they're going to respond in a positive way. If you said the hyporesponders, you're right. Now, these hyporesponders are so difficult to manage because they just don't ever get numb enough. You might be able to get them numb a little bit, but you just aren't going to get that profound anesthesia that you're looking for. And if you do get profound anesthesia, it's not going to last very long. Now, the duration of action, the times of duration of action will be presented to you in the form of a range. It's not going to be one specific number. It's going to be presented as a range. And the reason for that is because the exact duration of action really varies from one patient to the next. Now, these times are also presented in terms of pulpal versus soft tissue anesthesia, which can have some variations between them. Now let's look at, we talked about the individual response and now how that affects duration of action. Now let's look at how the accuracy of deposition influences the duration of action. Remember, we're looking at all these different factors that can really have an influence on how long your local anesthetic works. We said individual response is one, and now we're going to talk about accuracy of deposition. The best way to describe this in simple terms is by looking at the balloon race game, and you can see that picture right here. Now, most of you know this game, and if you don't, the goal is really simple. The goal is to shoot water into the clown's mouth to inflate the balloon until it pops. Now, the first person to do this wins. Now, you can only fill the balloon if you can spray the water directly into the clown's mouth. Okay, and the way that this relates to the accuracy of deposition of local anesthesia is that to get your target tissue numb, you have to deliver the local anesthetic in the right location. You might be able to get close, but if you don't get close enough, you're not going to get that profound anesthesia or the duration of action that you really need to get the job done. The type of injection that you give can also influence the depth and duration of local anesthesia. For example, nerve blocks provide more profound anesthesia than do local infiltrations. Now, this may be because in a nerve block, you're depositing local anesthetic adjacent to a nerve cluster, while local infiltrations, you're really just depositing the local anesthetic above the periosteum. Okay, so with nerve blocks, you're closer to the nerve sheath, and with local infiltrations, you are really just kind of depositing it anywhere above the periosteum. Now, anatomical variations between patients can really also alter the accuracy of deposition, and that decreases the effectiveness of a regional block. And that also, furthermore, limits the depth and duration of action of your local anesthetic. Now let me give you an example of this so that you can understand. Now, the example that I'm going to give is the inferior alveolar nerve block, or the IA block. You don't know very much about this because you're just starting this course, and you're going to learn a lot more about this in more detail later on. But the inferior alveolar nerve block relies supremely on depositing the local anesthetic in this area. You have the lingula here, and the lingula covers the entry of the inferior alveolar nerve into the mandible. Okay, this is our target location, though. We want to deposit it in the neighborhood of this lingula so that we can get a really good, reliable regional block. Now, here's the problem. Because this anatomical landmark can be in different places in different people, it's really, really difficult to get this consistently right every single time. Really, the best thing that I can say is that this anatomical variation between patients makes administering the inferior alveolar nerve block like hitting a moving target. You might be able to do it really well in one person because their anatomy is really ideal, but in another person who maybe has a shorter jaw and really a very different anatomy, you might not be able to figure out where that lingula might be. And so really these anatomical variations can negatively influence the accuracy of deposition of the local anesthetic. So it's really important not only to be familiar with your head and neck anatomy, but also to be able to translate that between one patient to another. So we talked about individual response, accuracy of deposition, the type of injection, and anatomical variation, and how all of those affect the duration of action of a local anesthetic. The last thing is something that we're really going to be revisiting from our last lecture, and that is the chemistry and the biology of tissues, which can also influence the depth and duration of action. Now, just like we talked about last time when we talked about inflamed or infected tissues and that their pH is quite a bit lower, more acidic, and that how that can influence what form the local anesthetic molecule is going to take, either the cationic form or the free base form. And that can really significantly limit the overall effectiveness of a local anesthetic. As far as the biology is concerned, the vascularity of a site can also do the same, because if you're injecting local anesthetic into a highly vascular site, let's say, for example, the absorption of the local anesthetic into the cardiovascular system can really greatly decrease its depth and duration of action. So if you're really injecting these into hypervascular sites, the vasoconstrictors that are present in the local anesthetic can do the job to shut down some of the blood vessels that are present in that site, but not all of them. And so some of your local anesthetic is unfortunately going to escape into the circulatory system, and that's really going to negatively affect that duration of action. Now, as I mentioned last time in our last lecture, some of our more medically compromised patients may have a relative contraindication to the use of local anesthetics. Now, here are some conditions on this slide that you may want to keep in mind while evaluating whether or not your patient's able to tolerate local anesthetics in the dental office. You'll notice that just because a patient has a severe liver or kidney problem does not mean that they can't have local anesthetics administered to them. You'll probably just need to have a medical consultation with their physician to see what it is that you need to do to modify your treatment plan. So typically, just out of experience, I'll tell you that typically with patients that are renally compromised, let's say they are on end-stage renal disease and they have to undergo dialysis every other day. Typically for these patients, there's not a whole lot of concern just because their blood is going to be filtered and cleaned every other day. Now, I say that with a caveat. And the caveat is that if you're doing minor procedures that require small amounts or very small, almost negligible volumes of local anesthetic, and the patient doesn't have any other considerations like taking medications that might increase systemic toxicity, then you're probably going to be okay. But if the patient is not only renally compromised and is also taking some other medications or has other conditions that might worsen if you introduce a chemical agent, then in those situations you're going to have to work a little bit more closely with the physician, with the nephrologist, to try to find the best solution and the best approach to provide oral health care to this patient. Same thing goes for hepatically compromised patients. If they you'll probably run across quite a few patients that have hepatic cirrhosis, and the hepatic cirrhosis will negatively affect the way that their bodies can biotransform or metabolize not only local anesthetics but also drugs. And so it's really important to talk to your physician, your patient's physician, and also the hepatologist or their liver doctor to make sure that you guys are on the same page about what you're going to do for this patient. Really, methemoglobinemia, we talked a little bit about that last time with respect to using prilocaine. And remember, orthotoluidine is the toxic metabolite of prilocaine that can actually trigger methemoglobinemia in someone who's already kind of prone to that. So significant liver dysfunction, significant renal dysfunction, significant cardiovascular disease. And this really kind of talks about what epinephrine does to the vasculature in patients who are already compromised. An alternative drug would be local anesthetics with epinephrine concentrations of 1 to 200,000 or even 1 to 100,000, or to use mepivacaine or prilocaine with no epinephrine formulated into them. And we'll get to the specifics about these three local anesthetics in just a moment. Clinical hyperthyroidism. The clinical hyperthyroidism is pretty self-explanatory. You can't upset the apple cart too much with patients that have this condition because it can really cause some negative clinical presentations for them. But just to be aware of your medically compromised patients and why and when and how to provide them with local anesthesia. Now, we just finished discussing the factors that affect the depth and duration of action. Now we're going to go on to discuss the topic of maximum recommended doses and how it relates to the normo, hypo, and hyper responders. First of all, why do we calculate a maximum recommended dose? Well, presumably it's to know how far we can go, right? It's so we know how much anesthetic we can give a patient without harming them. Unfortunately, it's not that simple, especially when we remember that every patient responds differently to the same amount and type of local anesthetic. Now, if we were to take a normal responder, let's say, and calculate their maximum dose, we would expect that the maximum dose would produce blood levels below overdose thresholds, right? And that makes sense. Now, because they haven't gone over their maximum, they should be okay. Clinically, though, they might still exhibit mild symptoms of overdose, such as tremors or drowsiness. Now, if we were to do the same thing for a hyporesponder, we may not see any clinical signs or symptoms, even if we administer anesthetics well above their calculated maximum. So their blood levels may have entered overdose territory, but you may never know it by looking at them clinically because they're just not showing symptoms. On the other hand, a hyperresponder may exhibit clinical signs and symptoms well below overdose thresholds. So what does this tell us? What does this tell us about a patient's response to local anesthesia? Well, really, it tells us that even if we stay within a patient's calculated maximum dose, we really can't predict how they're going to respond. So if a maximum recommended dose can't predict how a patient will respond, why use it? Isn't it just a pointless number? Now, the answer to that question is no, it's not a pointless number. What the maximum recommended dose gives us is a line in the sand that we should never cross. Because we know that a patient has a greater likelihood of experiencing adverse effects if we go over that maximum dose, it's really important to keep that in mind. But you should always also keep in mind that a patient may respond in a variety of different ways below their maximum threshold as well. Now, this is really, really important when we talk about two vulnerable populations of patients, children and the elderly. Now, when it comes to these two groups, you have to be really, really careful when giving them local anesthetics. Children have a smaller blood volume than adults and reach toxic levels much quicker. The elderly are not able to process and eliminate these drugs as efficiently as a younger, healthier adult, and therefore they are also more prone to building up systemic toxicity. So I'm going to show you how to calculate a patient's maximum dose right now. Now, a helpful tool when calculating maximum doses is knowing what each drug's individual maximum recommended dose is. And this number comes from the manufacturer. Now you can see those on the left here. And this is really difficult to see on the screen, but I want you to actually blow this up or expand this so that you can actually see the text here. But these are the recommended maximum doses that are given by the manufacturer. Now you'll notice that you can either calculate them in terms of milligrams per kilogram or milligrams per pound. You'll also notice that there's an absolute maximum dose that should not be exceeded per appointment. Now, what's the difference between the two? And hopefully you caught just now that I talked about two different types of maximum doses. I talked about the maximum doses that are calculated according to the patient's weight. And I also talked about a maximum dose, an absolute maximum dose that is given by the manufacturers of these drugs. And what's the difference between the two? Well, I'm going to call this one the calculated maximum dose that you have to use for the patient's weight. I'm going to call that the relative maximum dose because it's relative to the patient's weight. I'm going to call the other one, that's the absolute maximum, I'm going to call that the absolute maximum dose. Now, a drug's maximum dose is a dose that should not be exceeded. Even the absolute maximum dose is a dose that should not be exceeded even if the patient's maximum dose that is relative to their weight is higher. So let me give you an example to clarify that. Let's say that we had a 400-pound patient. Now their maximum recommended dose for lidocaine would be calculated by their weight, right? And it would be calculated by taking 400 and multiplying that by 3.2, okay? So that's articaine, so here's lidocaine, 3.2, okay? So we're 3.2 milligrams per pound. We have a 400-pound patient, and we multiply 400 by 3.2. Now, that's going to give a relative maximum of 1,280 milligrams, which would translate, and I'm going to show you this math in just a moment, but that would translate out to 36 carpules. 36 carpules. Now think about that. Each one of those carpules, as you remember from last time, if they have epinephrine in them in the formulation of 1 to 100,000, each one of those has 18 micrograms. So we know that too much epinephrine can cause a lot of problems. Okay, so for this 400-pound patient, the relative maximum relative to their weight is 1,200, almost 1,300 milligrams. Okay, obviously that amount of local anesthetic and vasoconstrictor would pose a serious threat to this person's well-being. So that's why the manufacturers actually include an absolute maximum dose. And this absolute maximum dose completely overrides the relative maximum dose that's calculated by the patient's weight. Okay, so the most, in this particular situation, the most that you could give this patient is 500 milligrams, and that translates out to being 13 and a half carpules. So that would be a safe maximum dose for a patient who's a little bit heavier. So to calculate the patient's maximum dose, you need the following two things. So write this down. And this is to calculate a patient's relative maximum dose. You need two things. You need the patient's weight, and that weight can either be in kilograms or it can be in pounds. And you need the manufacturer's maximum dose by weight. And that number is this number right here, the 3.2 that we used. Okay, you need something to multiply against the patient's weight, and that is the manufacturer's maximum dose by weight. Now, I told you that I was going to give you an idea of how to calculate how many carpules. You remember just a second ago I said this 400-pound patient, if we were to calculate their relative maximum dose relative to their weight, it would be 36 carpules. Well, how did I calculate that? Well, this is how you calculate it. You need two things. So I just told you two things to calculate the patient's relative maximum dose. Now I'm going to tell you that you need two things to calculate how many carpules are represented by the patient's relative maximum dose. So the first thing that you need is the patient's relative maximum dose. And the second thing you need is the number of milligrams of local anesthetic per carpule. And that's what this is right here. This on the right-hand side of the screen. You'll see that milligrams per mil, there's about 1.8, 1.7, 1.8. This says 1.7. Some of the carpules you'll come across have 1.8. I did some digging, and I think that this 1.7 actually is like 1.77 or 1.78. So sometimes they just round up to 1.8. But anyways, the entire carpule has a total volume of 1.7 mils or 1.8 mils, okay? And the total milligrams per mil is right here, and it's according to the amount listed for the particular local anesthetic that you're looking at. So for example, articaine has 40, bupivacaine has 5, lidocaine has 20, mepivacaine has 20, prilocaine has 20. So you see right here at the bottom it says 1.7, and right here they round it up to 1.8. So what you do to calculate the milligrams of local anesthetic per carpule is that you do the following. We know that for lidocaine there are 20 milligrams per every mil, but there's not just 1 mil in a carpule. There's 1.8 mils. So you multiply 1.8 times 20, and then you get 36. What does that mean? That means that in one carpule of local anesthetic, you have 36 milligrams of lidocaine in that carpule, or you have 9 milligrams of bupivacaine in the carpule, or you have 72 milligrams of articaine. Why are these numbers different? Well, it depends on the percentage. So lidocaine is 2% lidocaine. Mepivacaine, the formulation that we typically use, is 3% mepivacaine. Articaine is usually 4% articaine, and so forth. So you'll see the percentage on the carpule. You'll also see the total volume of the cartridge on the outside of the carpule as well. But now we know how to calculate how many milligrams there are of any given local anesthetic at any concentration, as long as it's 1.8 mils, right? And they all are. So there's no worry about having to try to figure out for a different volume. So now we know that we have in a 2% lidocaine solution in a carpule that has 1.8 mils in it, we have 36 milligrams. Okay, so the patient's maximum dose and the milligrams of local anesthetic are what we have per carpule. Okay, so let's see how we can calculate how many carpules the patient's maximum dose represent. Now, give me just a moment to bring up my calculator so that I can kind of give you some pointers on how to calculate this. Okay, so what you're going to do is you're going to take the patient's relative maximum dose, and remember, that's relative to their weight, and you're going to divide it by the number of milligrams per carpule. So let's use the patient that we just talked about before. We have a 400-pound patient, and we know that lidocaine's maximum per unit of weight is 3.2. So 400 times 3.2 is 1,280 milligrams. Now you remember we said that that's way over this absolute maximum. But let's see how many carpules that makes. So we take that 1,280 milligrams and divide it by this number right here, 36, because we know that there's 36 milligrams per carpule. So we take 1,280, divide it by 36, and we get 35.55555. So in essence, 36 carpules. Okay, and that's how you calculate. That's how you calculate how many carpules the patient's maximum dose represents. In this particular case, the maximum dose was 1,280, and that represents about 36 carpules. So let's go through and do another example. So we have a healthy 22-year-old female patient that weighs 50 kilograms. And you can do both. You can do the kilograms or you can do it by pounds. What is the maximum dose of lidocaine we can administer to this patient? And how many carpules does that represent? So remember, we just talked about these numbers for lidocaine. So for the maximum dose, we need two things. We need the patient's weight, and you need to decide whether you want to do it in kilograms or in pounds, but it's about the same number. And you also need the manufacturer's max dose per weight. It's that small number on this previous screen. So it's this middle number if you're calculating it in pounds. It's this other number if you're calculating it in kilograms. Okay, so we know that so let's do it in kilograms actually. So 3.2, and so in kilograms it's 7 for lidocaine with vasoconstrictor. Okay, so we know the person is 50 kilograms. Okay, and what is the maximum dose of lidocaine? So then we're going to take 50 kilograms and multiply that by 7, and that gives us 350 milligrams. How much does this represent? So how many carpules does this represent? So remember, we do that by taking 350 and dividing it by 36. You'll remember that there are 36 milligrams per carpule, and that gives us an answer of 9.8 or 9 3/4 carpule. Now, the second question is pretty simple. We answered the what is the maximum dose of lidocaine that can be administered for this patient, and the maximum dose that we're talking about here is relative maximum dose, and how many carpules. That one we take the relative maximum dose and divide it by 36 in this case for lidocaine, and so we get 9 3/4 carpule. Let's do another one. Here we have a 40-year-old, and by the way, if you want to just read the screen on, if you want to read the problem on the screen and pause the video and do it on your own and then see if you got it right, which I'm sure you'll get it right because the answer is practically on the screen. But if you want to kind of go through these calculations on your own just to make sure that you're doing them right, please feel free to pause the video and do that. So I'm going to give you a couple seconds. But here we have a 40-year-old healthy male who weighs 90 kilograms. What's the maximum dose of articaine that can be administered, and how many carpules does that represent? So to calculate this patient's maximum dose of articaine, we take the weight, which is 90 kilograms, which is 90 kilograms, and multiply it by the maximum dose per weight as provided by the manufacturer, which is, if we go back to this, articaine, it's 7 because we're doing it in kilograms. So we take the weight, which is 90 kilograms, multiply it by 7, and the answer that you should get is 630 milligrams. Now, you take the 630 milligrams and divide it by, let's go back to this other chart, and for articaine, in a 1.8 ml cartridge, there are 72 milligrams of articaine. So you're going to take that 630 milligrams, divide it by 72 milligrams, and you get about 8 3/4 carpules, or 8.75. One last example. We have a 7-year-old healthy child that weighs 20 kilograms. So we take the 20 kilograms, multiply it by 6.6. And why are we multiplying it by 6.6? Well, we're giving mepivacaine. And the number for mepivacaine, instead of going back to that other chart, I've just provided it on this sheet, is 6.6 milligrams per kilogram. So you have a 20 kilogram patient, multiply that by 6.6, and you get a maximum of 132 milligrams of mepivacaine that you can give. This is the relative maximum dose. This translates into about 2.5 carpules, a little bit less than that. When you take 132 and then you divide it by 54, which is the other number, there are 54 milligrams of mepivacaine inside a 1.8 milliliter carpule, and that gives you about 2.4 carpules. Now, with kids, and this is very, very important, so please pay close attention. With kids, you want to round down. So with this particular child, you want to not exceed 2 carpules. Okay, even if the child is a little bit older, if their weight is not high, you really don't ever want to exceed, for a 2% formulation, you never want to exceed 2 carpules. Okay. So hopefully this is straightforward for you. And one really quick question. What do you do, and I'm sure that you've come across this already in the clinic as you've been observing other dental students, what do you do if you're using more than one local anesthetic? For example, you were down in the clinic in oral surgery and they used lidocaine and then articaine, or they used lidocaine and then they used bupivacaine. Which maximum do you use? The simple answer is that the total dose of both local anesthetics should never exceed the lower of the 2 maximum doses. So lidocaine's maximum dose is 500 milligrams. That's the absolute maximum. And bupivacaine's is 90. So the total should never exceed 90. And this means that you can give 72 milligrams of lidocaine and 18 milligrams of bupivacaine, which totals 90 milligrams. If you have any questions, please feel free to send me your questions. But hopefully that's pretty straightforward for you. Now, this slide shows you something a little bit different, and so we're going to move on to this different thing. We talked about the different formulations, the 2%, the 3%, and how is that calculated. Now, the 2% formulations are calculated by taking 2 grams, or 2,000 milligrams, and dividing it by 100 mils. This gives you a number here. This gives you 20 milligrams per mil. If you take 2,000 milligrams divided by 100 mils, this is what you get. So this is what you get is 20 milligrams per mil, and that's how this is calculated. Okay, 3% is done in the same fashion, 4%, and so on. Now this number can then be used to calculate the milligrams of local anesthetic in a carpule. Now if we take the carpule's total volume to be 1.8, and multiply that by the milligrams per mil, then we get the milligrams of total local anesthetic in the carpule. So let's do an example of that. We have how many milligrams of anesthetic are in 0.5% cartridge of Marcaine. So in 0.5% formulations would have 500 milligrams per 100 mils. And that would equal 5 milligrams per mil. So if you take 1.8 mil carpule, and multiply that by 5 milligrams per mil, then you have 9 milligrams of Marcaine. Hopefully that was clear. If not, please let me know, and I can work with you on this a little bit further. But the math should be pretty clear. So before we go through the local anesthetics currently used in the United States, we will talk about Procaine. And you remember at the beginning of the lecture, I talked to you about how we were going to talk about this local anesthetic that was really important historically in the United States in particular to the history of local anesthetics in dentistry. Procaine was really kind of the sole local anesthetic used for decades and even hundreds of years for dental procedures, and it was known as Novocaine at the time. It's classified as an ester. It's metabolized in the plasma by pseudocholinesterase, and it turns into PABA, paraminobenzoic acid, and most of it is excreted in its PABA form. Now, it was an intermediate drug that really didn't work on the pulp all that well, but it did give about 15 to 30 minutes of soft tissue anesthesia. So that's why you have all those horror stories of people just not ever getting numb at the dentist, decades back. Now, the problem with Novocaine is that, like other esters, it's a really intense vasoconstrictor, which means that it doesn't stay at the site of injection for very long. It was discontinued as a local anesthetic in the United States and is no longer in use. Sorry, I misspoke. I said that that Novocaine is an intense vasoconstrictor, but it's actually an intense vasodilator, which means that it doesn't stay at the site of injection for very long. I apologize about that. Let's see if I put that on. Nope, it's got intense vasodilatory effects. Okay, good. So really quickly again, Procaine is an intense vasodilator, and it didn't last very long. So hopefully you can learn how to distinguish Procaine from other formulations as we continue our discussion about local anesthetics right now. So I have to tell you a funny story. I'm currently recording my lectures in my shed. And the reason for that is because I have 6 wonderful kids who I love very much, but they can get a little noisy. So it's very difficult to find a quiet place to record these lectures. But anyway, I hope that you'll bear with me. So now let's talk about these other local anesthetics. That first one was the ester. We've kind of gotten that one out of the way. We don't really use it anymore. It used to be called Novocaine. It has a really big historical significance. Now, the first one that we're going to talk about is this 2% lidocaine, and it's found under the trade name of xylocaine also. It is classified as an amide local anesthetic. It's metabolized in the liver and excreted by the kidneys. Its duration is pretty intermediate. The approximate amount of time for pulpal anesthesia is about 60 minutes. And soft tissue anesthesia usually lasts about 3 to 5 hours. And it really, again, it kind of depends on individual response. How long it takes to get started working is about 3 to 5 minutes. And there are a couple of different formulations. First, you have the 1 to 50,000 concentration of epinephrine with the 2% lidocaine. And then you also have the 1 to 100,000 of formulation of epinephrine with the 2% lidocaine. Now, you'll notice, and something that I want you to notice from now on, is that these local anesthetic carpules are assigned a different color. Now, here in the United States, the 2% lidocaine HCl that has 1 to 100,000 concentration of epinephrine usually is banded with red. So it has a red band on it. The 1 to 50,000 usually has a green band on it. Now, we talked a little bit about the recommended maximum doses. So by weight, the relative maximum dose can be calculated, but the maximum dose by weight is 7 milligrams per kilogram or 3.2 milligrams per pound for lidocaine. The absolute maximum dose is 500 milligrams. That means that you don't ever want to give anybody more than 500 milligrams. Pregnancy risk category for this drug is B, which means that it's relatively safe. You should take special precautions for ASA class 3 and ASA class 4 individuals, also individuals that have cardiovascular disease. And lidocaine is really kind of the gold standard that we use in both medicine and dentistry. Moving on, we have 3% mepivacaine plain, and that means that it has no epinephrine along with it. Now, this one has a lot of different trade names. It's known as carbocaine in some places. It's known as polocaine in others, but it is 3% mepivacaine plain. This is also an amide local anesthetic. It's metabolized by the liver, and it's excreted by the kidneys. It's got a relatively short duration of action, and I hope that makes sense. The reason why is because it has no epinephrine with it that causes that vasoconstriction to help that local anesthetic stay at the site of injection. And its pulpal duration of action is approximately 20 to 40 minutes, with soft tissue being sometimes between 2 to 3 hours. I think those numbers are actually a little bit high, but that's what the book says. Your onset of action is about 3 to 5 minutes. There are currently no formulations with epi. This has a satin gold band, which causes a problem because, as you'll see in just a moment, there's another local anesthetic that also has a gold band, but it's a shiny gold band. And we'll kind of go through that in a minute. Maximum recommended dose by weight is 6.6 milligrams per kilogram or 3 milligrams per pound, and the absolute maximum dose is 400 milligrams total. This is a pregnancy risk category C, and the precaution that I would give to you is that just because this does not have epinephrine in it does not mean that it can't not cause damage. And so you need to make sure that you don't accidentally overdose your patient on it. This is also really great to use on patients with severe cardiovascular disease or anybody who really just doesn't respond well to the epinephrine. 4% prilocaine plain, also formulated in two different ways, really. It's formulated as both a plain formulation with no epinephrine, and it also has some formulations that do have epinephrine. This is known by the trade name of Citinist, and we do have some of this and the other formulation down in the student clinic. It's an amide local anesthetic. Different from the other ones, this is actually metabolized in both the liver and the lungs. It's excreted almost completely as metabolites by the kidneys. The duration of action is intermediate, so the pulpal duration of action is approximately 10 to 15 minutes, 40 to 60 minutes with a nerve block. Soft tissue is approximately 1.5 to 2 hours by infiltration and about 2 to 3 hours by nerve block. The onset of action usually takes about 3 to 5 minutes along with the other ones. The formulation with epinephrine can be found in a 1 to 200,000, and this is actually a black banded local anesthetic. So if you see it down in the clinic, it will actually have a black band on it. This is maximum recommended dose is 8 milligrams per kilogram or 3.6 milligrams per pound, with the absolute maximum dose being 600 milligrams. Pregnancy risk category C, and this is really contraindicated in patients with idiopathic or congenital methemoglobinemia. And it's also contraindicated for patients with any type of anemia, or if they have cardiac or respiratory failure by hypoxia. Now here's the one that I was talking to you about that sometimes gets confused with mepivacaine. Because it has a gold band, but I'll get there in just a minute. So this is 4% articaine, and it's a 1 to 100,000 epinephrine concentration that we have. It's known by the trade name of Septicaine. Now this is kind of a hybrid local anesthetic. It has some characteristics of an amide and also has some characteristics of an ester. So because of that, it's metabolized in both the liver and the plasma. Its excretion is almost completely excreted as metabolites through the kidneys, and its duration is intermediate. I actually like using articaine a little bit more than I like using lidocaine. Now, it's a personal preference. There's different theories behind why some people like to use lidocaine versus articaine or vice versa. But I really do like this particular local anesthetic. It's very effective, particularly for areas where you're working in very dense bone because it has really good bone penetrating properties. Now, the duration of this is intermediate. The pulpal anesthesia is about 60 to 75 minutes. Soft tissue anesthesia is about an hour and a half to 3. The onset of action is about a minute or two. And the mandibular block, it usually takes about 2 to 2.5 minutes to start working. And there is one of the papers that I'll have you read does have to do with using articaine to perform an inferior alveolar nerve block. Maximum recommended dose is 7 milligrams per kilogram or 3.2 milligrams per pound. There's actually no published absolute maximum for this local anesthetic that's published by the manufacturers, but I usually tell people to go by the 500 milligram total as well as lidocaine. Pregnancy risk category C, and we really don't recommend that you use this. It's actually relatively contraindicated to be used on children under the age of 4. And really the simple answer to why that is because we just don't have a lot of data on patients who are under the age of 4 who are being administered articaine. Bupivacaine is the last one that we'll talk about. It's in a 0.5% formulation, so 0.5% bupivacaine with 1 to 200,000 epinephrine. It's also known as Marcaine. And the classification is an amide, and it's metabolized by the liver and excreted almost completely as metabolites by the kidney. The duration on this one is really, really long. It's about 90 to 180 minutes, and the soft tissue anesthesia can go for as long as 8 to 9 hours. The onset of action, it usually takes about 6 to 10 minutes to start working. And as I said, the formulation is about 1 to 200,000 epinephrine. So this is a blue-banded local anesthetic. Maximum recommended dose is 2 milligrams per kilogram or 0.9 milligrams per pound with an absolute maximum of 90 milligrams. Pregnancy risk category C. Now, this local anesthetic is very interesting because it has such a high affinity. The molecules have such a high affinity. And you'll remember that we talked about the neurophysiology of these local anesthetics. They work on excitable membranes in excitable tissues. And other than nervous tissue, what else has an excitable membrane? Myocardium. The myocardium has an excitable membrane or excitable tissue, and so any local anesthetic that works on nerves will also work on cardiac tissue. Now, this is a problem because this particular molecule has a very, very high affinity to those receptor sites on the sodium channels. And what happens with this is that it can be kind of cardiotoxic. What happens is that it binds so strongly and it has such a long duration of action that it can actually cause some heart problems like myocardial infarction or cause some other type of cardiac event that is actually resistant to resuscitation. And so Marcaine is something that you're going to need to make sure that that you have permission from your attending to use on a patient, and make sure that a thorough medical history and even a medical consultation has been done on the patient before using Marcaine. Now, down in the clinic, especially in the oral surgery clinic, you'll have the oral surgeons there to help you to know when and when not to use it. If you were to talk to an anesthesiologist, they'd probably say that Marcaine really isn't that big of a deal, but for the purposes of why we use it here in dentistry and in dental school, I'm going to say that this is something that you need to have an attending's permission to use because of the cardiotoxicity. Now, getting back to articaine and mepivacaine. They both have very similar colored bands. One of them is shiny, which is articaine, and the other one is more of a satin finish, which is carbocaine. You need to make sure, and you can kind of see that the aluminum collars on the heads of both of these are different colors. One's silver and one's gold. You need to make sure that you read every single time that you read the name of the carpule on the surface of the carpule, on that sticker, before you put that into your syringe. Every single time. I really don't care if it's red, green, blue, black, gold, shiny gold, satin gold, whatever color it is. I want you to make sure that you read every single time when your assistant is handing you something, or a fellow student is handing you something, that you read that carpule to make sure what it is that you are putting into somebody else's body. Now, what are the 5 factors to consider when choosing a local anesthetic? How long do you need it to last? Will the patient be in pain after the procedure? How likely is it for your patient to self-mutilate? In other words, to bite their cheek, bite their tongue? Is hemostasis required? Are there any relative or absolute contraindications? So as you think about these questions, I want you to go back and answer these questions using, in your mind, answer these questions using the knowledge that you've gained so far. To not only to be able to answer the questions, but also to give you a little bit of that clinical guidance that you need, the clinical decision making that you need to decide to make choices on what local anesthetics to use and when. Now, I hope you've enjoyed the discussion. I think we've come in. I unfortunately said that this lecture was going to be a little bit shorter than the last one. I think we've probably gotten pretty close or gone over than the last lecture, but I hope that you've enjoyed this discussion, and I hope that you've learned. Please make sure to read the papers that I'll post on Canvas under the download section for this week, and also make sure that you take the quizzes and review all of this information. It will be really important for you before you get back into the clinic. I want to thank you very much for your attention, and please feel free to contact me if you have any questions. Thank you very much.